Hello, I'm Alex Nowbar. I'm a research fellow at Imperial College London, and I'm delighted to introduce Professor Daniel Mark from Duke. He's a cardiologist and researcher and also editor-in-chief of the American Heart Journal. So Dan, I heard that you spoke very elegantly about the results of Orbiter and ischemia, particularly the angina results. But if you were speaking to a patient, what would you say to them about having PCI for stable angina?
Throwing me a softball off. I think what we've learned on this is that the relief, that the benefits from the symptom and functioning side of things, if you will, in stable coronary disease is proportional to the degree of impairment or suffering that the patient starts out with when they present for care. So it makes a little sense to do an invasive procedure in somebody who has well-managed, very infrequent angina and is okay with that they've reached an accommodation with their symptoms. They know how to manage it. They're not afraid of it, or it's not limiting their enjoyment of life. And in that case, I think we have very little of use to offer by being more invasive, and good medical management is really the core of the patient's care. Somebody, on the other hand, who is very symptomatic probably deserves to have the option to consider the potential benefits of doing a revascularization, which, of course, before catheterization, you don't know what specifically they're dealing with. But
and another thing you mentioned at CVCT was the idea that patients get used to their symptoms and then they restrict their activities and then they have this new normal. And so when you ask them how they feel, they say they feel great. And then in the trial, you don't really get to show that your therapy is very effective. What can you do about that when you're designing trials to tease out that issue?
Well, people have struggled with this question for probably as long as we've been doing trials in coronary disease. And, related to some of the earlier discussion today, a lot of emphasis. So one of the interesting things about the patient-reported outcomes and the management of coronary disease, heart failure, and all the common cardiovascular diseases is that physicians have long sought a way of avoiding having to actually talk to the patient about exactly what their problem is, because there is this variability, which is hard for them to parse out. It's like, so thinking that, while I don't think it's intentioned as disrespect, but it's just the feeling that we have to have some anchor, something solid to really base decision-making on. And if the patient you can't get inside the patient's head and examine their sensations and what they're doing to sort of parse out, here's the important stuff that you really need to focus on, and that's related to your arthritis or your back pain, or it's just non-specific discomfort, don't worry about it. So what have we done? We've tried to find all kinds of various so-called objective testing methods to figure out who needs to be treated regardless of whatever they relate to us as a story. And, so stress testing, initially treadmill testing, and then stress imaging testing, and then more recently CTA. And we sort of come full circle in a way with, I think, with the combination of Orbiter and ischemia, back to, you basically have to talk to the patient and find out what's going on in order to decide whether or not they need something more than medical therapy. But to get to the specific issue that you raised, it's a good question that I don't think we have a good answer for yet. There is a little bit of perhaps the effect, and I don't know if this is true in the UK, but like in a lot of practices at Duke, in the US, including Duke, the stress labs are usually monitored by text. The doctor refers the patient to a stress test, but doesn't go with the patient to the test.
Yeah, it's the same as in London. Yeah.
So back when we were less important, perhaps, and had more time in the day to spend with individual patients, it wasn't uncommon for the doctor to go to the stress lab and observe the patient doing the test. And I think if you did that, you could learn a lot from what they're doing. But to receive the report and, this many meds, this much reason for stopping, these areas were ischemic, something, you lose a lot of that. Okay, you said you were doing fine, but you look terrible after the first stage of the Bruce protocol, and that's not very much exercise. I think something's going on here, and we need to figure out what it is. So, but I don't know. We can't go backwards. It is what it is. So we need some way of combining both types of information to you need function, you need patient's subjective information. And sometimes the patient's functioning is impaired by the fact that because they've accommodated to their disease, they've become significantly deconditioned.
Right. And so that doesn't really come into their quality of life assessment that we might do for them. No,
and Adrian Hernandez actually referred to this in comments that he made, and he and I have discussed it offline a little bit, but it's so when you're using these activity monitors to try to assess patients' functional status, the limit of that is if they've learned sedentary behavior, and then you apply some good, effective heart failure therapy or coronary disease therapy, whatever it happens to be, and they still have a sedentary pattern of behavior. And so you monitor, they haven't really improved their activity. The therapy must not be working. Well, no, that's not exactly the case. It's the case that they've just become habituated to being inactive. And maybe they're even a little bit fearful of testing where the boundary has moved to. They've just learned to live underneath the pain boundary or the dyspnea boundary. And now we're saying, we've improved you, but the experience of finding the boundary and seeing what happens, it may cause anxiety, may cause discomfort that they prefer to avoid. But also, as anybody knows who's had, any kind of prolonged illness, even a long flu, it doesn't take very long sitting and lying around to get significantly deconditioned, even when you're otherwise healthy. So once you've got a few chronic illnesses and some comorbidities, it's often hard to get back up the hill of fitness once you've allowed yourself to go past a certain point.
Thank you. It's so interesting to hear your opinions. And just a slightly off-topic question, I'm just interested. So you're a cardiologist, but how did you get into research? What was it? Was it serendipity? Was there some kind of significant life event that you ended up doing research?
The serendipity always plays a role, I think. My life could have gone a number of different ways, and it just happened that I ended up at Duke in a place which had a huge reservoir of really talented statisticians and clinicians, including Rob Califf and Frank Harrell and Kerry Lee, Mark Lackey, among others. And so we had this great pod. But before that, as a medical student, when I was starting my clinical rotations at Tufts Medical School in Boston, I was watching my elders, the residents, explain how they went from diagnosis to treatment decisions. And I found the whole thing completely opaque. It seemed like a totally random process, influenced to an unexplainable degree by whatever had appeared in the New England Journal that week. And I said, I don't know how I'm going to be able to do this. Like, I don't understand the basis for what they're doing. And so I ended up taking a year after medical school to get a master's in public health at the Harvard Public Health School. And that sort of identified me as somebody that people were interested in. So it was a good move. I won't say that I learned a huge amount there. It was just the beginning of a long journey of trying to understand this stuff. But there was some very formative exposures there that I think were helpful. And I differentiated myself at a time when very few physicians had, advanced degrees beyond the MD degree, particularly related to clinical research stuff. So it was the key thing that helped me to match with the laboratory at Duke, where I started off with Bob Rosati, who was actually the head of the lab at that time, and a very penetrating thinker. So that's a sort of short answer to your question.
No, that's great.
Serendipity stuff on the side, which might be
inspiring. Thank you. So Dan, were things a bit easier back then because you said that not that many people were doing that sort of thing. If you could just reflect on that.
Well, I mean, as a career move to move into what was we called it initially clinical epidemiology, which wasn't exactly accurate, and then it eventually got called outcomes research, which wasn't exactly accurate either. And from observational research, we moved into clinical trials with Rob Califf's leadership in the TAMI trials and the Gusto trial in partnership with Eric Topol. But I would say that there's an old joke that, it says that I don't know where we are. We're lost, but we're lost at a much more sophisticated place than when we were lost before. So I kind of feel the same way about, making decisions. I certainly feel much more comfortable that I know things that I didn't know before, but there's so much clearly that we don't know that every day when I'm taking care of patients, I feel the fact that we should understand this better and we don't. And,
I have a similar experience in my training that I can't always tell why the decisions are being made the way they're being made, and then I sort of realize that maybe there isn't evidence and people are using their experience and rather than evidence.
Yes, well, they're using experience is a tricky thing because we don't process experience the way a computer does. We tend to do it in a very biased fashion. And we call it intuition, which, I'm being a little bit cynical perhaps, but it's true. I think that our colleagues, when they get sick, they want to find somebody to take care of them who's got a lot of that intuition. So I don't think that we can totally discount somebody working strictly from the cookbook, from the guidelines is not going to be the person who is going to be sought out as the doctor's doctor, if you will. And I think that, some of my colleagues, a former colleague, Alex Vanneroff, for example, who's at UPenn, did a nice paper in, I think it was JAMA, maybe JAMA Cardiology, I can't remember now, where they looked at all the cardiovascular guidelines and what proportion of recommendations were class 1A. And it's a very small percentage and it hasn't changed in 10 years. So, we're rightfully proud of all the work that has been done in cardiovascular medicine, but it's like an iceberg. You know, we're looking at the top above the water. There's a huge piece under the water that is still essentially expert opinion in one flavor or another, peppered with some probably misunderstood outcomes research. And so the good news is there's jobs for us for a long time. We won't be obsolete.
Get some more 1As out there. All right. Thank you so much for speaking to me. It's been a pleasure.
Yes, thank you.